Live from the Washington, D.C. area, it's the Inside Scoop. All the news that our viewers want to know. Now, here's the host.
Welcome to Inside Scoop. My name is Bettina Lawton, and I'm your host. And tonight we are celebrating, a little bit late, it was actually last week, on April 16th. It is National Healthcare Directive or Decision Day, and it's a whole nationwide thing. They've been doing it for about 6 years, and the goal is to inspire, educate, and empower the public and providers about the importance of advanced care planning. And so tonight I have as our guest a medical doctor, Dr. Steve Simmons. He is with Doc Talker Medical Practice. It's in Vienna, Virginia, and he does a lot of work with older folks. And so I've heard him speak on this a couple different times and thought we need to have a doctor come on, because 3 years ago when I first started doing this show, I was a guest on someone else's show to say and talk about what advanced medical directives were, but I was doing it from a legal perspective. So we're going to get the mix tonight, the legal, the medical, and Steve Simmons is going to give that to us. So he is board certified in internal medicine. He is a member of the House Call Physicians Association, and yes, there are doctors who make house calls in this day and age, and also a member of the Geriatric Society. And he has also got a personal stake in this. He is a long-distance, long-term care provider for his own parents. So he's got some experience in the very things that we're going to be talking about tonight. So welcome to the show, Steve. I'm glad you could take time.
Thank you for having me.
Well, first I wanted to find out about Doc Talker, because most medical practices that I know say things like, you know, Dr. Simmons and Associates. What is Doc Talker?
Or internal medicine and family practice clinic or so on, right?
Right.
My partner, Dr. Dappin, started the practice with the idea that we would provide access to our patients in such a way that it was a pure doctor-patient relationship. And so the name denotes the idea that you can talk to your doctor with no one else involved in the conversation. It's a very private doctor-patient relationship, and we'd like to imply that in the name.
And you also do things on phones. People can actually call you up to talk to you, as opposed to a lot of doctors where you have to be physically in their office.
Oh,
right?
sure. Yeah, we'll take phone visits, email visits. Skype is HIPAA compliant even.
Really?
So for us in our practice, we're not married to the idea of a waiting room. We find that for about 50% of our problems that our patients have, we can do it without making them come to the waiting room, wait their turn, and then see us. So we'll support that with a phone, a car, whatever it takes.
Okay. And you guys do make house calls. I noted you belong to the House Call Physicians Association. Do you guys actually make house calls?
Yes. I'm almost 90% of my time is on house calls. I do most of those being an internist. I have a lot of experience in geriatrics and taking care of multiply complex issues. So those are the patients that tend to be trapped in the home and need the most help.
Oh.
So that's how I find myself. A majority of my time is in people's homes.
Now, do you also go out, speaking of older folks, do you also go out to like nursing homes and take care of people there, or assisted living places?
Assisted living, nursing homes, anywhere that a patient wants me to be their physician, I will follow them short of a hospital.
Okay. Okay.
So, some nursing homes you have to be credentialed at that specific nursing home. So it usually takes several weeks to get that done, so it's not easy to just show up at a nursing home, but it's a process that only takes a little bit of work, just a little notice, and we can figure it out.
Okay. Well, let's talk about how you ended up getting involved in educating and coming out and talking to people about end-of-life medical care, directives. There's this other document that I'd never heard of until I heard you mention it. An MOLST, I think, or something.
We're going to talk about the MOLST later, I take it.
Right, we're going to talk about the MOLST later. I mean, how did you get all involved in doing that instead of just doing sort of straight doctor stuff?
It's interesting when I hear when you say the straight doctoring stuff or the idea. I think we're all getting used to going to see the doctor and you have your problem taken care of, your chest pain or your ankle sprain or your high blood pressure, and when you're able as a physician to just focus on problems, you miss a lot of the more complex personal issues, which is what happens when you take care of patients. So when I started doing house calls and seeing people in their home, it was rather a shock of how little I was prepared to help them with what mattered the most. Sometimes you don't help a patient, or I can't help a patient with the right prescription more than I could help them by just getting them in touch with the right people, or explaining the realities of their circumstance and giving them options so they can weigh them out. So a lot of what I do now, I see as giving information to people to explain it in a way that they can understand so that they can make hard decisions. And so in end of life, it tends to be the hardest decisions, I find. It's usually quite a mess at times if you're unprepared, and then you find yourself infirm with a lot of variety of problems. It could be financial, it could be health, it could be even just relating with other family members. But it's a myriad of complex issues. And so I fell into it very slowly and was shocked how little I knew.
Wow.
And how little I was prepared by my training to handle these questions.
How little I knew is not a phrase that usually comes from a doctor's mouth, I must tell you that.
There's a lot I don't know, let me tell you.
Well, let's talk about the stages, because we keep hearing that life expectancy has gotten very long. So if you've got somebody who's in their 40s or 50s, if they're normally healthy, whatever that means, are they really expected? People keep saying you're going to live to 100. Is that really true? I thought it was a lot less than that.
Well, it's going to depend on who you ask. If you ask an insurance adjuster, you'll get your most accurate answer, I find, for how long you expect to live, yes. I just out of curiosity, I looked, and I could see that I was born in 1966. And my son, who was born in 2005, he can expect another 5 years on average. So it's, when you're looking at the life expectancy tables, you don't get to look at it for the year you're living. You look at it for the year you were born. And then you can see your estimate for how much time you could expect. I find it intriguing that you'll always have a separation in men and women's life expectancy. You know, I think we've all known that women outlive men on average. Right. It's about 5 years. But some of the statistics that shocked me is that the United States, we rank 51st in the world on life expectancy.
Really?
Yes. We beat Cuba and some other countries like that, but we're number 51. There's a lot of different reasons for that.
I was going to say, that is kind of shocking, because we consider ourselves to be so advanced, and we have all of this medical know-how and technology and drugs. I'm surprised we're so low.
I think that we do a very good job, best in the world, at salvaging very complex, hard medical problems. But we don't stack up when it comes to extrapolating our choices over millions of people and then making decisions on a higher level, so to speak.
Okay. So we're not good at the day-to-day making good decisions that help us live longer.
On average, apparently so, yes.
Okay. Well, let's talk about, because you had this great slide, I saw this, and so I want to put this up. I love this slide. It's behind us, so hopefully that folks will take a look at this. And this is you at all stages, which I just found really interesting, because the concept of advanced planning, advanced medical planning, of saying you as the younger person need to be making decisions for you as an older person. It's still you, but you can sort of see in that sort of scheme up there that if things about you just keep changing and changing, and I think people don't really focus on it because it's every day something else changes a little bit.
Yeah, the reflection in the mirror seems the same day in and day out, doesn't it?
It does, and then all of a sudden you're like, wow.
This picture, it captivated me for a long time when I first saw it, and for me, it made me aware that whomever I am seeing, whether they're young, middle-aged, older, I believe I have a responsibility in the doctor-patient relationship to each one of those people, not just the person I'm seeing at the time. So if I'm seeing you at 40, I feel a responsibility to the 80-year-old you, even if I may not be around to be the doctor that cares for that 80-year-old person. And so then I can extrapolate it to myself. This is a continuum through life that we need to be aware of. And we can make decisions today that influence who we will be tomorrow.
Well, and that's, when I talk to my clients about medical directives, that's what I keep sort of saying to them, is you have to plan what you want going forward. You need to make the decisions today for the you that you're going to be much later.
I promise you one thing for sure. You're making decisions whether you're aware of it or not, and they will influence who you will be tomorrow. That is a guarantee.
That's the sort of no decision is still a decision.
It's a huge decision.
It's a huge decision.
Absolutely.
Well,
I would like to say one other thing about that that I think would be interesting, is a concept that you try to live your life from a medical standpoint in such a way that your problems must stay peripheral to who you really are. And you can make choices that will lead to chronic illness where you no longer have that luxury and that you have to move a disease into the center role of your life. And I had an older physician tell me 2 or 3 decades ago that everyone makes a choice, consciously or subconsciously, to be in charge of their disease or their disease in charge of them.
Wow. It's true. I hadn't really thought of it that way, but it is true. Well, let's talk about the why we ought to be doing this. Why for advanced directives? Because that's what we're here to sort of talk about. Why should they do this? You know, as I say to my clients when I'm counseling them from the legal aspect of this, is we want to make sure that whatever you want to have happen, when you can't make your decisions yourself, that we maximize the chance that that's actually going to happen. And so you have to sort of talk them through different scenarios and what do you want, and then try and find somebody, the agent that you're going to name, who will actually do it for you. And which is the big thing. I mean, you've got to have somebody.
Not always as easy to tell as you may think.
No, it's really, and I've had people. I had one lovely woman who wanted to have a fella as her agent. He was a great guy, but he had been diagnosed with brain cancer when he was 18, and he was now in his mid-30s. He beat it. They told him he was going to die. And she was someone who didn't want extraordinary measures, didn't want any of that. And I said to her, he can't do that for you. That's not his life experience. His life experience tells him that you could beat it. And you don't want to do that to him. You don't want him doing it to you because you won't get what you want. But you don't want to put somebody like that having to act against their own belief system.
No.
So it's much harder, I think, than some people think to come up with the right person to do this for you.
Yeah, I think my parents liked the idea that they had a doctor in the family, so they could just pick the doctor in the family and be done with it. So if you have a doctor in the family and you like their bedside manner, go with them.
Go with them, exactly. Well, you know, you have to figure that out. Most people aren't that fortunate. So, and the fact that you do the kind of work that you do. So, well, we are going to go to break, and then we are going to come back and talk some more with Dr. Steve Simmons.
Okay.
Too many women get hit by their boyfriends and husbands. Too many women are pressured into having unprotected sex. Half of the people in the world living with AIDS are women. It doesn't have to be this way. Together, we can change this reality. Let's strive for a world free of violence.
At Volunteers of America, we don't just give kids a way to stay off the streets. We give them the tools they need to reach their full potential. We don't just help the elderly receive needed care. We help them live life to the fullest. We don't just provide food for homeless individuals and families. We provide job training and placement so they can buy groceries. Volunteers of America is a national organization that for over 100 years has provided programs and services that allow people to overcome their challenges to become vital members of their community. At Volunteers of America, we don't just help people, we help people help themselves. Find out how you can support the programs that are working in your community. Contact Volunteers of America today. Call 1-800-899-0089.
Drivers face all kinds of distractions.
Guys, stop playing. No. 127 consecutive.
Before your wireless phone becomes one of them, stop. Drive safely. Keep your phone in easy reach and dial sensibly. In bad weather or traffic, call later and use a hands-free device. Remember, with wireless, safety is your call.
we're back to the Inside Scoop. Here again, your host.
Welcome back. This is Bettina Lawton. I'm your host of Inside Scoop. And with me tonight is Dr. Steve Simmons, and we are discussing advanced medical directives. They're known by a variety of names, and we're going to go over that in a few minutes. But first, when we left, we were talking about why get one. And we have a slide up in the back. And what I really want to ask you about are two things on this. It says in the big bold, 1.4 million are currently alive through feeding tubes. And then in the smaller underneath it says 30,000 people are comatose in a permanently vegetative state. So I always think of feeding tubes as what the people in the comatose states have. So who are all these, in my view, extra people on feeding tubes? What's that all about? Why would somebody be on a feeding tube?
Well, you would hope that a vast majority, and I believe a vast majority, are short-term. And by short-term, I don't mean a day. I mean, you could be a year, a half a year. You would hope that most of these patients are using it as a bridge to a healthier state when they can support their own ability to eat. However, a lot of people, if you have a stroke and you lose the ability to swallow, or you have advanced neuromuscular diseases such as multiple sclerosis, myasthenia gravis, there's a lot of different illnesses that could leave you unable to process food as you swallow and safely get it into your stomach. And so just with these variety of medical illnesses, that is necessary. So a lot of people have feeding tubes and yet are able to look at their iPad or read the paper and watch the news and converse with their family.
Wow, that is just so not my
conception. It's a little different than your, sure.
You know, I think Terry Schiavo and I think feeding tubes. I think
right, but that's where you need to understand the idea of the persistent vegetative state. So a lot of times we'll use terms that have very precise meanings, and I find that the legal profession and the medical profession understand that words have specific meanings. Right. Okay, so what would happen is if you start with a patient with a coma, what you would do is you would think in terms of about 2 weeks that will declare itself in one of three ways: either recovery, death, or a persistent vegetative state. So a lot of times people in a quote-unquote coma, again, one of those three outcomes. Now, if you end up with a persistent vegetative state that has a very specific definition and is different than recovery, of course. However, 2 weeks is a rule, and there are exceptions. So you have the sensational stories of the person who maintained themselves in coma for years and then recover.
Right, and that's the thing that when I talk to my clients and say, you know, what do you want done if you're in this persistent vegetative state? They will always say to me, but maybe I could recover. And so we ought to sustain me basically forever in this persistent vegetative state. And they always cite the one person, the one...
Yeah, but that's a coma, not a vegetative state.
Okay.
So there's a very specific definition.
So what's the difference then?
Okay, and again, with medicine, when you start to get into tricky definitions like this, what you find instead of a nice 1 or 2 sentence definition that you can take with you is there's a list.
Oh, great.
We love lists. Okay, so so what I would say is, I brought a little bit of this here, there would be no evidence of awareness or self or environment and an inability to interact with others. And this, if you see somebody who has a coma, their eyes are closed, they're obviously not looking at you. But what you have with the persistent vegetative state is, one definition I found is people who suffer a severe anoxic brain injury and progress to a state of wakefulness without awareness, which is different than a coma. Eyes are closed, not looking at you. So what happens when you get to a persistent vegetative state is that person with a coma, their eyes open, they're looking around, but there's nobody home, so to speak, which is a very tragic. And then you could have a variety of, well, just a whole variety from there, depending on the actual brain injury.
Now, can you tell, is there a test for persistent vegetative state? You know, that they hook you up to a brain scan or something? And
it's interesting, you're almost there. That's where you're getting into brain death.
Okay.
And most frequently when you're looking into like an organ donation situation where maybe somebody had a terrible bleed in their brain and yet all their organs are functional. What you would do is you would do certain tests with imaging studies. You could do EEGs. Different tests are done to demonstrate that they have brain death, but the rest of the body is alive. which is different than, some of the tests would be similar for a persistent vegetative state, but in looking at that horrible outcome for someone, you'll see a variety of clinical pictures that you're looking for.
Okay. That actually is something, when I was meeting with some clients over the weekend, they talked about when we were talking about organ donation, and they were very concerned about how would somebody know they were really dead.
Well, I'll tell you one very important thing in brain death to separate that from a persistent vegetative state is someone with a persistent vegetative state, you may have them being kept alive with a feeding tube, but not with a breathing machine, so to speak.
Oh, really?
Where they should be able to have those automatic processes sustain them through life. Whereas brain dead, you can't unhook them from a breathing machine without them in seconds or minutes expiring. They don't have the basic primitive brain function to even breathe in and out.
Wow.
Which would be different than the persistent vegetative state. You have a wakefulness but no awareness.
So does anybody then recover from persistent vegetative states as opposed to the comas?
This is where, as a rule, no. As an exception, people will say, but of course, and yet you have to really look at the small print on a case-by-case basis to see if you really believe that. It's controversial. I think that if you chose either answer, I would have someone after me.
Okay. Well, let me ask you something else then.
Sure.
Is there a time frame? Because this is the other question that always comes up when I'm talking medical directives with people.
Sure.
Is there a time frame where they say, all right, like you said with a coma, in a 2-week period, maybe on average, you'll know which way you're going on. Is there something that says if you have been in this, if you're getting treatment for something and it's not helping you, that if you say, keep me alive for 90 days, that by the end of 90 days, we ought to be pretty sure what's going to happen, versus I've got other clients who say, I want to be kept alive for a year, just in case.
I've heard every number.
Yeah, there doesn't seem to be a straight number, but is there any notion that somehow if you were to say you're in the coma, you've moved past that 2 weeks, you've moved past that month, you're still there?
I don't think you're going to get it to where it's absolute or black and white at that point. It's just going to be where the more and more time you get out past that 2 weeks, 3 weeks, 4 weeks, then the less and less likely it is that you would have recovery. Okay. But I'm not aware of a hard, cut, fast rule.
Okay. I always kind of wonder about that because it's, people, they don't want to give up too soon.
No.
But they also don't want to linger and have the financial impact on their families, and also just sort of that prolonged grief for their families.
Hope can be a healing balm, or it can be an acidic torment if used incorrectly.
Yeah.
I'll tell you.
It's true.
Yeah.
That is true. Well, let's talk about, there are a variety of medical directives out there, or things that people think of as medical directives. And I know a number of folks who did their plans like 20 years ago. I think the longest I've had is a client who came and they had had their plan done 29 years ago.
Wow.
And decided with their first grandchild that maybe they didn't need a guardian for their own child anymore.
Wow.
It was one of those types of things. So there are a lot of old documents out there. So people, the first one that started, it was called a living will. And so if you have a living will, what is that? Because that's not today's version. That's more a fundamental, rudimentary kind of thing?
Right. It wasn't that. I believe that was in the late 60s, early 70s when they started coming up with the idea that perhaps you could dictate some of what happens to you when you can no longer make your own choices. It was very, well, I don't know, it was like the Wild West. Everybody had their own, right?
Right.
So there wasn't really any standard. And so then over time you would see that there's more of an attempt through different generations of living wills and advanced directives to be more precise.
And is there any different from a doctor's perspective? I mean, the living will piece I always see in terms of the big broad statement. You know, if I'm in a persistent vegetative state or I have a terminal condition, I don't want you to take extraordinary measures. That's all it seems to do.
Or except for 2 weeks.
Right.
Or, yeah, exactly.
That kind of a thing. But then there's these healthcare proxies, and I've seen them, and in some states they still call them healthcare proxies, which
fallen out
don't
of vogue,
have
that term now, though. Yes.
Yeah, they really don't. Those seem to me to be much more detailed. And usually there's a document that would say healthcare proxy and one that would say living will. So that, which I was never in favor of. I'm always of the view, if you've got two separate documents, you're going to lose one of them. And so let's
or there's got to be some mathematical formula about how quick it'll be that they contradict each other,
right,
too,
exactly.
let me tell you.
Exactly. And that's something that I always say to folks,
spend days on something like that.
Well, and what do doctors, when where we are today with this, particularly in Virginia, we have this advanced medical directive, and the front end of it seems to incorporate what we would traditionally call a health care proxy. It's more of the details. You designate an agent, and the back end of it is sort of end of life, living will type stuff.
You can make choices.
You can make choices. So what do doctors pay attention to all of this minutia, or do you just look and say, who's making the decisions? That's who I've got to talk to, and it's up to them to know the rest.
It depends on who you're talking about.
Okay.
And for me, I must say that before I was doing house calls and really becoming enveloped in end-of-life care, I didn't pay that much attention to it either. We're not trained to really look at it. It actually invades the average flow of a physician's office, I find, to bring up something like that. It's messy, it takes a long time, and it can even be controversial. I can remember, I forget the specifics, but a couple of years ago in the summertime there was a fuss with healthcare reform over talking about end of life and
death panels.
The death panels. You got to have a catchy, pithy little phrase to make sure that nobody knows exactly what you're talking about, right? Which is really frustrating for me. But with all these negative connotations that you'll find in discussing this, I find that it's the kind of problem that a patient, a family, you have to take it on head on. And you have to lead on that. You actually cannot wait for a modern physician in this country to really have the time or find the interest to bring it up and lead you through how to fill it out.
So if you've got a doctor, do you want, like in your practice, if I come in and I have my medical directive, you want to see it, you want to scan it in, stick it in my file, you want to have all of that. People ought to be doing that to give it to their doctors.
Absolutely.
So if I bring mine in, are you going to sit down and go over it with me, or are you just going to say, thank you very much, Bettina, and stick it in my file in case you ever need it? How does that actually work?
Well, I mean, if it was you, I'd probably just stick it in there.
That's a lot. I
think you're going to have worked it out. But you know, no, it depends on the person and really who's there. It has to be a case-by-case for me. But what's interesting in Maryland, going to a nursing home, if I don't produce a document like that first, I can't get them into a nursing home.
Oh my God.
So there are places where it's an admission ticket.
Well, we are going to come right back after the break to continue talking about this with Dr. Steve Simmons.
She's had more than a dozen fractures. And in the next few years, she faces 2 major surgeries to strengthen her fragile bones. She's only 10 years old. Most people don't worry about fragile bones until late in life. For those with osteogenesis imperfecta, brittle bones are a concern throughout their lifetime. Find out how you can strengthen this child's future.
Diabetes is a killer. After I was diagnosed, I didn't feel sick, so I didn't listen to my doctor. Then it struck. I had a heart attack, then a stroke, and I was only 49.
Most people with diabetes also have high blood pressure and cholesterol, which can cause severe heart damage. In fact, 2 out of 3 people with diabetes die from heart disease or stroke.
Don't let diabetes destroy your life.
Call for your free diabetes survival guide. Choose to live.
We're back to the Inside Scoop. Here again, your host.
Welcome back. I'm Bettina Lawton, the host of Inside Scoop Virginia. Tonight we are talking advanced medical directives with Dr. Steve Simmons with Doc Talker, a medical practice in Vienna, Virginia. And I wanted to talk with you a bit about the concept of the agent and who you choose, because I think it's important for the agent to be able to confront doctors, to be honest with you, to be sort of challenging the doctors about what their advice is and what happens if you say yes or no and where do you go. I mean, what do you think? There's some book you mentioned one time about people ought to read this book if you really want to deal with it.
Well, first I would have to say you have to advocate for your loved one if you find yourself in an agent role. To not advocate for your loved one after being placed in that role will leave you with such guilt and second guessing for years. So you have to take it very seriously, and unfortunately you have to at times approach medical care as a consumer almost, and really with a discerning eye. And so the book was How Doctors Think, I believe. It was very,
It's a little scary, actually.
Yeah, it was written by a doctor.
Think.
It was written by a doctor,
Okay.
and in it he talked a bit about. Do you want a doctor who just makes lists and then follows a certain order, or do you want one that has a pattern recognition? He talked a bit about the thought process, and he gave very many examples, even of himself as a patient, when he knew he wasn't being listened to. Normally, if you think you're not being listened to, you're not. I find.
Right.
I find that as a patient.
Right.
No, it doesn't matter when people know I'm a doctor.
Right.
We don't get listened to sometimes as well.
Oh, good Lord. Well, and how do you, I mean, if you are somebody's agent, because the medical directives are pretty vague. There's not a lot of guidance in many of these things. So when you're the agent and you're trying to deal with the doctor and figure it out, presumably, I mean, do you sit down with people and talk about what their agent has to do before they get into the crisis situation? If folks come to you and want to figure it out?
I don't normally find myself talking to the agent that's been named. I normally find myself speaking with a patient, and you had alluded to the idea of a MOLST earlier, which is an acronym. We have acronyms pepper our existence these days, and it stood for Medical Orders Life-Sustaining Treatment. Okay. And every state has their own form. Some states you can just every state but Virginia.
I was going to say, I'm thinking to myself,
Virginia's the exception.
Does Virginia have
That's
one?
right.
I'm thinking, oh my gosh, I'm behind the times here. I must not have.
In fact, I'll print the one from Maryland, and I will actually, if I want to use it, I'll scratch out Maryland and I'll write Virginia on it. Oops. And I feel pretty good about it, actually.
I was going to say, is it legal?
I have not, well, it's not at this point a legal document like it would be in Maryland, but it sure is a nice guide.
Well, what is it? Because we were going to talk about that anyway, so let's talk about it now. What exactly is this thing?
It allows you to specify certain things. For instance, tube feeding, you would be able to say 2 weeks. I would like to have a 2-week trial of a tube feeding, and if it doesn't work and physicians judge that it's not going to work, then stop. Just the Virginia MOLST has several different sections on it where you could think about a variety of problems that your agent may face, and you can leave them instructions on what your specific preferences are. But then when the agent comes in is when something occurs that can't be thought of in advance and pre-programmed, so to speak, with a form like that. And so let's say that you said, I only want to be given tube feeds for 2 weeks, and you could then have it where then the agent would need to discuss with physicians whether to remove this type of treatment modality or not. There's every permutation. But to me, the MOLST is a chance for you as an individual to specify some specifics. And then you need your agent to be there to decide for you if your circumstance is outside the specifics you preordained.
Now, who fills this MOLST out? Is this something that a doctor fills out, or is this something that the patient fills out?
Well, I can tell you in the States, and I've had the experience, of course, in Maryland, where I practice, and I've had a little experience with Family Matters in some other states. But for Maryland, like I said, a nursing home doesn't want to see you without it first. Because they don't want to be posed with a 2 a.m. problem with a patient and then just have no choice but to call 911. They want to have some guidance on how to not send a patient inappropriately for tertiary care, which would be considered at a hospital. And so then in North Carolina, which would be just one quick example, you actually can't download it off the internet. You have to go to the doctor's office and get one.
Oh, really? So it's
Absolutely.
very rigidly controlled.
It's very
there.
rigidly controlled there. So it's different jurisdictions will have different approaches on it that I've found, more from personal family issues and then from practicing in a 3-jurisdiction area like I do.
And so so some states with this MOLST require the doctor get involved and actually talk to the patient about it. And then DNRs also have to be done by doctors, right? The do not resuscitate orders. And
It has to be signed by a physician, absolutely.
And I know you can't put them in advanced directives, so...
They're a bit different.
Yeah. So you have to, the doctor has to do this, and then apparently you can't do it unless some crisis is arising? It's not like I can do it a couple of years ahead of time. There has to be some more urgency.
Well, you could do a DNR ahead of time. You could do a DNR in theoretically, if you had it filled out, look, I may step over. Maybe there is a time limit I don't know about, but I'm not aware of it.
Okay.
And I know that the idea is that there are emergencies and then there are emergencies. And the DNR is going to save you from being unnecessarily brought back from the brink of death in a you have minutes to live situation. Whereas the living will and everything else we've been talking about is more related to days, weeks, years. The DNR is more about the next 5 minutes and what to do. And if you don't want to have chest compressions that could break your ribs and you don't want to be shocked at the end, you're really advanced in age, you better have one of those signed and really handy near you, because paramedics don't have the luxury of waiting 3 minutes until you find it in a desk drawer.
Right.
They will have to just do it without it. So what it is it becomes a don't do this sticker, so to speak, that you can have near you. The people who really get it, I find it taped on the fridge, the door to the bedroom, and behind the patient on the wall.
Wow.
Yeah, I've seen it there. And a lot of the assisted living centers now, when I admit a patient, it's almost like giving out autographs. There'll be 5 or 6 of them, and I'll have to fill them out. And every time the patient goes to the ER, they have to call paramedics. They just give it to them. Here's one. And so it's pretty interesting. We're doing more and more of those for each patient now.
And the default position, when you mentioned the 911, if you call 911, they're going to come, they can't wait. Is the default position, if you call 911, that's saying do everything you can? Because when they come in, they're not going to read
not
your
necessarily.
directives?
No, not necessarily. I don't view it as that at all. They could come and tell you whether you have an emergency or not. And you know, there are emergencies other than just being shocked and given chest compressions. You could, it could be as seemingly innocent as an old person with diarrhea that just needs some IV fluids. And yet you look so horrible that your family couldn't get you in the car and get you out. So you call 911. And I mean, really for the family, they're just going to look at mom looking really horrible and know they need to go. But it's not a situation where their heart stopped beating. It's not a situation where they quit breathing. The DNR is just about not breathing or your heart not beating or both.
Okay.
They tend to happen together a lot. So.
Right.
Right.
Well, let's talk about the Virginia standard, because these documents, you can sign them, but like your medical directive actually doesn't take effect until doctors decide you're not capable of making an informed decision. That's sort of the standard.
And it's two physicians.
It's 2 physicians. Yes, yeah. So how do you actually determine that somebody's incapable of making their decisions?
It's very intriguing. A lot of the times it's a process that unfolds depending on who is notified of an individual who can't make their decisions. It could be the courts, it could be adult protective services in my practice, it could be the law. You know, it could be it's a variety of ways you find out that someone can't really make their decision. For me, the most common example would be someone with Alzheimer's that maybe they left a pot on to boil and the kitchen caught on fire, you know, or some other variety. It's a surprising amount of reporting the car stolen at the mall, and yet it was right there.
They just couldn't remember.
Yeah, I've seen a variety of these moments, right? And so what happens is then the family rallies, everybody gets along, and then I get called. And so then frequently I'm asked to come into the home And a lot of the time it's about starting that process. All right, do you think that mom is okay to make decisions or not? And then let's say that I think she's not, and I write my medical work up. I do the best diligence I can to eliminate reversible things, such as a thyroid condition. There's an example in a list of things that a person could have dementia and you can get rid of it. There are reversibles, but the percentages are sadly less than 1%. Oh, okay. But I think everyone has the diligence or is owed that check. Once you're done, then, and I'm willing to say it, I will write a letter and I will attest to the incapacity, get that legal term in there.
Right,
then you have to find another physician to do it. A lot of times for my practice, since we have multiple providers, we'll have another provider go out and do the assessment themselves. And you can use a host of tools, mini mental status exams. There's a lot of different tools we can use, but a lot of times it could just be social examples, you know, almost burn the house down and such.
Okay, so it's, because that's the kind of thing that I keep saying to my clients, listen, this is not, you don't sign this and somebody else is suddenly taking away your authority to make your decisions. There has to be this in writing certification by 2 doctors that you can't do it.
That's right, and then the other person's making decisions. And a lot of times patients, when your mental faculties are lost, you can make some really horrible choices about what to do right now when you're sick. Right, exactly. Let me ask about the mental health authorization. A couple of years ago, Virginia added this to their medical directive, designed, I think, to do away with the requirement that you do a commitment proceeding, because those things are just devastating. And I've had clients call and say, you know, mom is just not herself and she's getting taken advantage of financially, and what are we going to do? I can't get the checkbook away from her. And it's like, well, if you really can't get her to agree with all of this, you're going to end up having to do some kind of a commitment hearing, and nobody wants to go that, because it's just, that's a really hard process to go through. Have you been involved in those? Are they? I have a few times. More often, I get to hear the unbelievable story, which almost should be filed under, "Are you kidding me? Really?" Really? You know, you hear that a lot, right? Yeah. But for me, it's quite often that I'll see it more after. But I have been involved several times, and just one that strikes a memory to me is as soon as I started it, I was told, "Well, you're going to have to be here at 6 in the morning," and you know, they really build it as you're going to have to make a huge commitment. Yeah, makes it tough. It's very tough. It's hard to find the time. Yeah, it is. And so we're going to take a break, take our last break, and then we're going to come back and keep talking about this mental health, because I find it fascinating. So stay with us. We'll be back.
Art, a universal language, an expression of culture, of self, and now, thanks to Empowered Women International, a way for emerging and established immigrant and refugee artists and artisans to find hope to earn a living while enriching the lives of all of us. Empowered Women International, making a better America every day. For more information on Empowered Women International's educational programs, or to make a tax-free donation, contact cfrip@aol.com.
Here, kitty, kitty. Here, kitty, kitty, kitty. Here, kitty, kitty.
You'd think it would be easy to tell which kids have trouble with their eyesight. But that's not always the case. Even though 1 in 4 children may have a vision problem, eye doctors tell us the symptoms aren't always so obvious. We do know that 80% of all childhood learning is visual. And without good vision, kids can have trouble learning to read. And may fall behind in school. For clues on how to spot the real-life signs of childhood vision problems and what parents can do, visit checkyearly.com. A public service message from the Vision Council of America and Reading is Fundamental.
We're back to the Inside Scoop. Here again, your host.
Welcome back. I'm Bettina Lawton, the host of Inside Scoop, and with me tonight is Dr. Steve Simmons of the Doc Talker practice in Vienna, Virginia, and we are talking about medical directives and trying to get some reality. There's a lot of forms out there, but how does this stuff really work? And one of the things that we were talking about was this new mental health opportunity where if you have some kind of a mental illness, there's a special section that you can fill out that says, I'm going to let my agent commit me for up to 10 days into a facility if a doctor at the facility, so it seems to me that's like a third doctor. You have your first two saying you're incompetent, and you get another one at this facility saying, yeah, you got a mental illness, and yeah, we can help you, and in you go for 10 days. And one of the things that clients say to me is, well, after the 10 days, do they have to let me out? And it's kind of this worry of like one flew over the cuckoo's nest or something, that if you say my agent can help me with mental illness problems, that you really have going to be losing control. Can they keep you in forever under a medical directive like this? Can they just keep saying, yeah, give me another 10 days, give me another 10 days? Did you ever see that?
I've never seen that. You would have to be really overt and quite obvious to have people do that. I actually think as an example, I'm thinking of an example, like if you go into the emergency room, you bring your loved one who was as an extreme example, homicidal. You know, you catch them, and I could give you live examples, stashing knives around the yard to ambush the neighbor. Oh, so, you know, if you get a circumstance like that, and then you bring that loved one into the emergency room, so the emergency doctor would be the first one. And then if you're lucky enough to find a bed in a mental health institution, then that would probably be the second person that would agree. I think that would be your numbers there. But to do that involuntarily, because let's say the person hiding knives doesn't want to go, then now I'm going to have to, as the emergency physician, or perhaps me seeing you in the home, I'm going to have to have the time to go to the hearing and to spend a lot of time backing that up. It's not good enough. I can't really write a note and says this is what it is. I'm a doctor. You know, I have to change my schedule for the future. And if you're booked in for an appointment with me, I have to cancel that because I have to now make this legal proceeding be the center of my schedule.
To do an actual official commitment.
Absolutely. But as far as the every 10 day, there's not near enough beds to have anybody stuck anywhere for 10 days. Because in that particular example, they sent him home with instructions to not let him stab a neighbor until they found a bed days later. So,
oh my gosh.
The resources aren't there really to hold someone for that long, I find.
Wow, that's amazing. That's amazing.
It's a lot that's amazing about that.
Yeah, and that's really unfortunate because we've got so many people out there who have mental illnesses, and you keep reading about how all the resources are being taken away with the budget cuts. So it's very tough.
It's almost like a dirty little secret that nobody wants to really address, especially if it's elderly and dementia. In that particular example, that was the problem, is that all the places we call it, well, we have a bed, but we don't admit dementia with psychosis. And then you look to the government, you know, and FDA, no one's really studying how to help dementia patients with psychosis. They just tell you can't use any drugs for it, actually, which was it's its own story. But it's quite an abandoned population, I think, by science, by government, and a lot of times by the resources that are really short.
Oh, that's discouraging.
Sorry. It's true,
really
though, I'm afraid.
Discouraging. Now, most people, is there a typical response? Do people, when we get to these sort of end-of-life decisions about, do I want you to do everything possible versus just let me go ahead and die, sort of this natural death, keep me out of pain? Everybody wants to be kept out of pain. Do the majority of the people opt for that these days? It used to be very controversial, and it was sort of
to just go for like comfort care measures?
Yeah, just comfort care.
I would find most people seize upon that concept.
Oh, really?
Better than the medical community, actually. I think that they're more keep me comfortable comfort measures, where the breakdown would be for I guess what a physician would call a lay person or a lay approach, is that what that really means, comfort care. You know, it's could be anything in anyone's mind. For me, it would be anything that would cause suffering or impair your ability to protect your own human dignity. Any of that would count for me.
Okay. Well, let's talk about different ways, because I've mentioned the provision in the Virginia statute. There's actually a form. You can go to the Virginia statute, and it's actually at 54.1-2984 for those who are taking notes. But there's also something called...
Say that more than once.
Yeah, more than once, that's right. 54.1-2984. There's also this document called the 5 Wishes, which
Absolutely.
I know a lot of people really like. Do you like the 5 wishes? You know the 5 wishes. These.
You know, really, I don't want to sound, sort of touchy-feely, but I really like anything that has been done ahead of time so that I have a starting point to the conversation.
Okay.
And I like it. I like anything that implies homework's been done ahead of time, and I don't have to broach these concepts anew. So I like it.
Okay.
I love it. I like people coming prepared to discuss this. I really do.
Okay. This is, I will tell you, I had a client a couple of weeks back who had the 5 wishes done and had a medical directive done. Different agents listed under each.
Oh, really?
Yeah.
That figures. What was it? It's almost like the study that showed, I was telling you about in the past, that showed that a vast majority of decisions that are made by proxies is inaccurate, is not consistent with the wishes.
Well, and what can you do to avoid that? I mean, these are sort of uncomfortable conversations for people to have, but the whole idea is that the agent knows what you want.
That's right.
So
spell out what you can ahead of time. That's why I like the living will and I like most forms. I think it at the very least, it's going to give your agent a guide and in a window into the thought process of you. Because you're not going to think of every circumstance possible, I promise you. Science hasn't.
Right.
So there's going to be exceptions, and then they're the ones that make the news, and everybody focuses all their energy on the exceptions. But give as many examples as you can.
You know, I say to my clients, think about what it would look like. What do you want it to look like? So that, there are some people who say, oh, if I'm trapped inside and I can't communicate, then don't do that. I don't want to have to be that sort of shell laying there, and I'm in there, but I can't ever communicate, or I can't move, or I can't, because my concern is always the people who want to say, I don't ever want, if I get this disease, I don't ever want, to have to live with that. And then I think, but you could sign these documents and we could say that, and in 2 months there could be a cure. And you're not going to remember to go back and fix this document now that there's a cure. So it's kind of like if you can explain to your agent not so much the specifics necessarily, but sort of generally, what does it look like if you're going to survive? If you are now in a position where somebody else is making your decisions, what do you want them to do? How do you want to live? And sort of come at it from sort of the visual end of it as opposed to the specifics.
I would say make sure you have a discussion about quality and try to avoid one about quantity when you're making end-of-life decisions. A lot of times we get caught up in saying you want as much time as you can, and you approach the medical community as if we were time brokers selling you weeks and months. I would suggest that you try to have a discussion on quality. I mean, it could go to religious beliefs, to just human dignity, towards the things that you don't want to see happen to you that happen to your family members or friends.
Well, and that is something that prompts, I think, a lot of people to start doing this kind of thinking, is when it happens to someone they know, or they read about it.
Sure, I was telling you, I think I've told you in the past, I think there's, 3 kinds of levels of preparation, It's the on time, and then the, what was it?
Ahead of time, on time, and too late.
That's right, ahead of time, on time, and too late. And 99% of the time it's too late to do it with any dignity. So, I don't think it is too early to have these discussions. I think that if you're, advanced in age, it makes sense to do this and not leave this as a burden to your children. I, as a physician, in trying to make decisions for my parents, I know that it's a very slippery slope if I treat my patients and if I treat my parents, right? And I would say that children, don't get yourself in a position where you're treating your parents. There's guilt involved in that can be lifelong. So try to have conversations with your parents. Encourage them to fill it out and give you enough guidance so that you can be free of guilt over choices that you've made. I find that guilt and the fear of guilt on a subconscious level drives a lot of chaos when you're one of those people who waited too late.
When you waited too late. Well, and that is the problem. I always, people say, well, this is just a hard conversation. And I'm like, well, you know what? There are opportunities. You can read in the Washington Post a couple of Sundays ago, there was somebody who had written a book about him having to be, he was an author, and he had written on end-of-life issues, and then had to do it for his mom. And so they did this book review. And I'm like, you can look and say, hey, look, this guy, and it opens up the conversation. There was a great cartoon ad years ago, actually for National Healthcare Day, that MetLife put out, and it was Snoopy on top of his doghouse talking to the bird, saying, boy, could you imagine not being able to recognize your best friend? And it was like, wow, it was great. It was great.
You don't expect it from that quarter. It'll shock you when you see that one.
Exactly. And it was like, but these are opportunities to have these kinds of conversations. And so people need to have it, because as you say, the guilt of not knowing what you're doing, and that statistic you had about 70-some-odd% of the time the decisions are wrong.
Yeah, and it would be opposite of what the individual would have wanted.
Right.
Yeah, none of us are good enough to know what another person is thinking. I don't care how close you are or were to them.
Right. You've got to ask. You've got to have these conversations. Well, and you mentioned the religious beliefs, and I discovered recently that the Catholic Church has its own version of a medical directive, that in the archdiocese in Arlington and Richmond got together on this, and you can actually find that on theirs. And I did wonder about that, because in it, and in another one that I saw that a priest had prepared, they referred to different encyclicals, and there were gospels being cited, and I thought to myself when I read them, does the doctor actually do that, research that, or you really have to have your agent be completely familiar with those kinds of belief systems if you're going to use that form that says, I want you to follow the teachings of the Catholic Church, or whatever church happens to be the one.
Yeah, I would hope for a Catholic agent, since I'm not Catholic in that circumstance, yes.
It would be tough. Well, I'd also say to folks, make sure you know what when you go to different hospitals and practices, make sure you know if they're religiously affiliated, because they may have beliefs that make it difficult for them to do what you want them to do. Also, all the hospitals have a patient advocacy office. It may have whatever name it has, but you can always go to a patient advocate's office and get these forms and get information at any hospital, I believe. Excellent. Well, I want to thank you for coming and taking time tonight to talk about this. Hopefully we've provoked some thought on people, and they'll go out and do their planning in advance. So thank you so much. So I don't have to have another too late consult. That's right.